So good afternoon, everyone. We're being joined by a few more guests who are just coming in and taking their seats, but we might get started. So it's now my great pleasure to introduce and welcome to RCSI a true pioneer of modern healthcare improvement, Dr. Don Berwick. Dr. Berwick is internationally recognised as one of the world's most influential leaders in improving the quality, safety and humanity of healthcare. As a paediatrician, an author, an educator and an advocate, his life's work is focused on one simple but profound question. How can we design health systems that serve patients better, more equitably and with greater compassion? He's the founding president of the Institute for Healthcare Improvement, an organisation that's transformed care delivery worldwide, helping systems to focus not only on clinical excellence, but also on patient experience, on safety, and on value. His leadership has inspired countless clinicians around the world to believe that better care is not only possible, but it is achievable. Dr. Berwick has served at the highest levels of public service, not just in his own country, where he led the US Centres for Medicare and Medicaid Services, but also around the world. His work for our near neighbours in the UK led to the publication of what became known as the Berwick Report, a commitment to learn, a commitment to act. That work defined 4 guiding principles for safer healthcare that remain true to the present day. And those are that we place the quality and safety of patient care above all else, that we engage, empower and hear patients and caregivers throughout the entire system and at all times, that we foster wholeheartedly the growth and the development of staff, and that we insist upon and model in our own work thorough and unequivocal transparency in the service of accountability, trust, and the growth of knowledge. And so today we're hugely fortunate to benefit from his insight, wisdom, and vision. And I know that you'll join with me in giving a very warm welcome to Dr. Don Berwick, who will deliver the President's Lecture on Quality and Safety in Surgery, entitled, How Big is Quality? You're very welcome.
Well, thank you so much, President McNamara. It's an absolute honor and pleasure to be here with you. I have not been in Ireland for about a decade, and coming back here to Dublin is just a joy. And what an amazing city, and what a wonderful country, promising country in terms I'll be sharing with you. My visit has already been a pleasure. I want to especially thank Cara McVeigh and the staff here at the college, who has made things so smooth and pleasant for me. So thanks again for the chance to be with you. A few disclaimers, as I haven't been here in a decade. I don't know anywhere near as much about medicine and surgery in Ireland as I wish I did, and so it's a little hard for me to contextualize the points I want to make in terms of your country. I will try, but I need you to be translators and see what works and what doesn't. If we have time for a little question at the end, you may want to correct some of what I say. With respect to my topic, quality of healthcare, it's actually 2 sets of problems we deal with now. There's the current one about the mess this administration is making. I'm actually not going to talk much about that. They are tearing apart the infrastructure for great care and public health in America. But it would be wrong to say that that's the only problem we've had. By no means at all. For a century, we've had defects and issues in healthcare in my country and yours that have been the object of my career, to try to understand how things go wrong, how things go right, and make sure that we are using all the knowledge we possibly can in healthcare to do well by our patients and the communities we serve. And that's what I'm going to be talking about. My entry into this field, I'm a pediatrician by training and practice, but my entry into the topic of quality came in the 1980s when I was working away as a health services researcher at Harvard, and continually kind of frustrated by the way the healthcare system was performing. People were trying hard, and there were really miracles, of course, but my patients sometimes failed to get the care they needed, sometimes in my hands, sometimes in hands of others. But it was frustrating for me to see errors and defects in care, despite the enormous goodwill of the clinical workforce. I tried as hard as I could, but there were patients who died on my watch who didn't need to die, and I knew it. And I didn't want to tolerate it. I wanted to find out what ways to deal with it. Now, the hegemonic approach, the kind of one that's there if we don't change, is it's very prevalent, and the approach is try harder. It's your patient, Dr. Berwick, and if something goes wrong, it's on your watch, and try harder, and next time. This constant driving attempt to force the workforce to do better, to do what it really wants to do in the first place, actually. And that generates a vicious cycle of blame and shame and combat, which is quite prevalent. The report that you mentioned, President, was called a Promise to Learn, a Commitment to Act. It was the report I wrote with a committee at the behest of then Prime Minister David Cameron about the Mid-Staffordshire mess, in which really dozens of patients died unnecessarily. And we had the data that it was perfectly evident that things were going wrong, but nothing was done about it. And the anger and the sense of betrayal in that country was enormous. There was a 1,700-page report written about all the mess. But the bottom line was a kind of idea that we have to hold these people accountable. We have to try harder. Well, one of my mentors, W. Edwards Deming, who was really one of the great thinkers about improvement of complex systems in the 20th century, used to say, "Trying harder is the worst plan." I'm not a perfect doctor, but despite my efforts, no one could try harder than I was. Things went wrong. It's a bankrupt idea, and we need to think differently as professionals and as a public about a different way to think about the way things get better. And that's the field I'm in. It's quality improvement, the continuous improvement, which is highly scientific, very well developed, and not adopted in healthcare for reasons that I don't understand. And for now 30, 40 years, I've been working to help learn and figure out how to use these scientific approaches to understanding improvement to do better for our patients. I must say, in that quest, surgery and surgeons are essential. The discipline is so full of risk and so full of prestige that you are automatically leaders in this field, one way or the other. Leaders into the wrong thinking or leaders into the right thinking. To my delight, surgery has been a leader in this field, and there are great achievements now in the world of improvement in surgery, some of which I'm sure are represented on this Charter Day exercises you've been through. Oh, so that said, let me walk you through what has become now my thinking about the evolution of this endeavor of improvement over really decades now. I simplify it in terms of phases, and I want to explain what has happened and where I think we're going. I will ask respectfully that you and the College of Surgery here take advantage of the chairs you hold to lead in this proper direction, not try harder. Think differently about the way our systems work so that they can better serve people. The beginning was the world of improvement, project by project improvement. And that's the most familiar form of this, what I'll call the scientific foundations of modern improvement. It began with AIM, the idea of improvement. And I smiled as I remember my early entry into this field when I was approached by a group of surgeons at Harvard to coach them on how to set up a quality assurance committee within surgery. And I said, well, why don't you begin by naming it a quality improvement committee? And I remember the hand shooting up at the back of one of the doctors who said, oh, we couldn't do that. That might imply that we're doing something wrong now. That was the beginning, but we rapidly left that and began to identify particular, specific issues in quality of care that we might work on through projects. By a project, I mean organizing an effort, usually in an organization umbrella, to say this thing is going wrong, and can we get organized to reimagine and then redesign the relevant processes so they can be more reliable. Surgery's been a leader in that field. The examples are abundant, but back to principles, the key is aim, to decide to improve something. For years, there were kind of rather random efforts. And then actually in the United States, in my country, in the National Academy of Medicine, the attention was paid to what we ought to be making better in two very important reports, transformational reports in the U.S. In 1999, a report called To Err is Human, and in 2001, a report called Crossing the Quality Chasm. Still relevant. I believe these reports still provide a powerful framework for understanding the dimensionality of improvement so we can pick things to work on. Dimensionality of improvement is an important idea, that quality, this word quality, which is sort of a vague term, it is an umbrella for whatever you regard as good about what you do, that is goodness. In the Academy's work, and I confess I had a strong hand in writing this report, so that's why I like it. But the first few chapters were reviews of the literature on things, what goes wrong, and ended up settling on 6 dimensions of quality. If you ask what's the quality of your automobile, you would then name dimensions. Well, it's fun to drive, it's low gas, high gas mileage, it's easy to repair, it lasts a long time. These would be dimensions of excellence. So does medicine have dimensions of excellence? And the 6 that were outlined in this report became rather canonical. Safety, which is you don't mean to injure the patient, but patients get injured at a very high rate by the care that means to help them. So safe care. Effectiveness means application of scientific knowledge to that patient so that they're getting the benefit of processes and diagnostic and therapeutic maneuvers that have evidence behind them. Patient-centeredness was a radical idea that we shouldn't be driving the car, the patient should. That what really ought to orient us is what matters to you. And we change the direction of our drive depending on what the patient tells us matters to them. That's become more radical, as I'll show you in a few minutes, but it's almost patient control now, and I think a very, very important idea in quality. I remember speaking to a friend who was about to have a hip replacement, and he was a very, very prestigious physician. You would know his name if I gave it to you. And he said he was deeply touched by his surgeon's interview with him before the surgery. And he said that the doctor said to me, "How would you like to be after this operation? How would you like to be after this operation?" And this very distinguished physician began crying. He went into tears because that's such a powerful, tender question in which the agency and efficacy and respect that he feels by having been asked that's quality. How would you like to be after I'm done trying to help you? Timeliness is a reduction of delay. That's what brought me to the UK and my work under the Blair administration, trying to reduce delays. Delays are usually defect unless they're instrumental for observation. Efficiency means reduction of waste, which is rampant in all our healthcare systems. Despite the fact that you spend almost just about half of what we do per capita in the US, the waste levels in Ireland and England are high. And you may know that as surgeons, as you see things happen around you that don't help the patient, and who invented this, who suggested that I do this. And then equity is big in my country, big issue. Still racial inequity is rampant in the United States. A black baby born this year in the US will live 7 years shorter than a white. And that's a quality dimension. So this was the guidance we got from our Academy of Medicine in 2001 around what we might work on through projects. And that works. An early piece of research done by my colleague, Dr. Rick Shannon at West Penn Allegheny Hospital at the time. Rick, unlike me, believed that central venous line bacteremias were not inevitable. When I trained in medicine before pediatrics, and when I was in the intensive care unit, 1 out of 10, 1 out of 12 patients with a central line got bacteremic. It came with the territory. I thought I was wrong. Rick and pioneers like him said, no, these are not necessary. If we apply very, very disciplined routine management to central venous line care, the science was there, it just wasn't being used. And Rick at West Penn Allegheny was able to drive central venous line rates, bacteremic rates to zero, or very close to zero, simply by working on absolutely reliable application of knowledge to practice. The airplane I flew to here from Boston has defect rates at parts per 10 million. That's how reliable aviation got. It's not by pilots trying harder. It's by an entire system focusing on reducing defects. Defect rates in healthcare are parts per 10, not parts per 10 million. The project-by-project work on central line infections is a good example of really disciplined work. In the country of Scotland, your Celtic cousins, Derek Feely and Jason Leach, and eventually the First Minister in Scotland, at that time Nicola Sturgeon, got very interested in quality improvement in healthcare. She was the health minister at the time, and began using a national approach to applications of very disciplined improvement methods to surgery and surgical care. That wasn't the only thing they were working on, but over about a 6-year period, Scotland achieved a 23% reduction in cervical mortality, attributable, I think, to a collection of very clear projects that were done nationally. First, I must say, against the resistance of physicians, but eventually with wholehearted participation of physicians in every hospital and municipality. Dramatic achievements in safety, probably the best in the world at that time. It's become global. This is work in Saudi Arabia in a hospital, big teaching hospital in Saudi Arabia, achieving central line infection rates of zero for now several years, none at all, eliminated. These are dramatic examples of giving up, trying harder, and instead putting in very disciplined methodologies for continuous process improvement. It does raise a question, which will come back in a minute, which is if it's possible to have central venous line infections pretty much go away through the application of disciplined process improvements, whose job is it to do that? And it's a tough question. I think I'm going to come back to it in a minute in other contexts. That I would call phase one. If you had stopped me in 1991 or 1998 and said 2002, what were you working on? I would have told you about projects like that. Not dozens, hundreds, maybe thousands, topic by topic. Big improvements. Problem was that an improvement achieved in one place, like West Penn Allegheny Hospital, would not necessarily spread to other places. We lacked curiosity or humility or something that would allow the best to become the norm. With the college, Royal College of Surgeons in Ireland, I think you have an opportunity absolutely to make that your dream, that the best is the norm. Who for any problem that might develop in patient care, what hospital or what clinic or what surgeons in Ireland are achieving the best results, and that becomes not optional. It is now the result we all want together, not fighting about it, but welcoming the learning. The second phase is harder to describe. The Institute of Medicine's panel of qualities, safe, effective, patient-centered, timely, efficient, equitable care, was good. I think it really did offer some chance of focus, but it wasn't big enough. And my colleagues Tom Nolan and John Whittington in 2006 came to me, I was at that time CEO of IHI, said, that's great, that's about the experience of care, but why do people get sick? Why are the heart attacks? Why are the broken arms? Why are there depression? And of course, you all know very well that that's because there's a causal system in our societies that create illness or erode health. You can't achieve health with health care. That's the embarrassing perception. Other things must be worked on. And Whittington and Nolan came forward with this idea of the triple aim, that you, should be dealing with a complex system of goals, which include safe, effective, patient-centered, timely, efficient, equitable care, but also reduction of threats to health, population health improvement. And the third part of the triangle here is reducing per capita cost of healthcare. In my country, spending twice what yours is, there's a phenomenal amount of waste, and there is also in systems at your level of expenditure. And they say that's not right. That money's needed by workers to send their kids to school, or by society to have better sanitation, or we're not entitled to that money. That money should go where people want it to go. And so waste reduction becomes central to the pursuit of improvement, and that's the triple aim: better care for health, better care for individuals, better health for populations, and lower per capita cost. That is a broadening of the notion of quality, which I'll say a bit more about if I have time, and it's really important. But there's also a second broadening that I want to spend a few minutes with you on. This is my best friend. I grew up with him from infancy. His name was Richard Bernstein, a writer for the New York Times. He headed their Berlin bureau, their Paris bureau, a very accomplished author and a lovely man. And Richard and I, we went to the opera together 1 year from today, I think, in New York, had a great time. But a few weeks later, he called me and said I wasn't doing so well. He was feeling fatigued and out of sorts. Long story short, within a month, he had the diagnosis of metastatic pancreatic cancer. I helped him through this journey as best I could, and he called me one Friday afternoon. He had a liver biopsy to pin down the diagnosis and the genetics of the tumor and so on. And he said, I said, how did the biopsy go? And Richard said, fine, but I don't understand something. When the biopsy was done, I asked them when I would have a result. Now, please understand, my best friend was sitting on the edge of his seat. He knew the game. He knew the severity of what was going on. He also knew there were genetic subtypes that might propose a more favorable response to chemotherapy. His fate, to that extent, hung in the balance. And he asked when he'd have the result. He said the answer they gave me was in 5 business days. And my friend, the journalist, said, "Isn't there something wrong with that answer?" I think everything's wrong with that answer. It is blind or deaf to the condition of my best friend suffering with uncertainty at that point. 5 is the wrong number. I'm sure it's possible to design systems that would produce the answer he needed in much fewer than 5 days. Believe me, if it were the prime minister, it'd be done in hours probably. I'm not a pathologist. I don't know the minimum processing time, but it's not 5 days. The other thing wrong with it is the word business. So how does this enter the mentality, he was asking me gently, when I'm suffering and scared, terrified? And the answer is it's the wrong word. It has nothing to do with the question my other friend was asked, which is how would you like to be? It's a deaf. It's a defect. It's a serious defect. And for this failure of quality, I ask who is responsible for changing that? Who shall make it so that that answer will never be given in a hospital truly focused on patients? I don't know. I think it's governance. I think it's the board of directors, the executive structure of the organization, and the leading clinicians who say, we're not going to agree to be in a place that says to my suffering friend, 5 business days. That is a different kind of broadening of the goal, and it's a much more centering of the patient's experience in the definition of quality. It is possible to do otherwise. This is my wife, Anne. We just celebrated our 50th wedding anniversary. And she's an athlete of sorts. I mean, she's out every day. She'll be out on a trail somewhere. In the old days, hiking. In the current days, not, because she has the side effects of a mysterious myelitis that has given her quite a bit of difficulty walking. But she's really game. Except that 3 years ago, she began developing extreme fatigue on exertion. She couldn't cross our living room. And it eventually turned out that the reason was that the pacemaker lead, the right ventricular pacemaker lead she was paced because of atrial fibrillation, had destroyed her tricuspid valve. She had no tricuspid valve. it was gone. And so she needed the tricuspid valve replacement, and we eventually ended up in the hands of Dr. Tor Sunt at Mass General Hospital. If I had more time, I'd describe Dr. Sunt exactly the attitude we would have wanted, we did want. She had the replacement. It was terrifying. 10 days of post-operative recovery, threats to her fluid balance and her electrolytes and her cardiac rhythms and infection. But long story short, it all came out right, and can ride 30 miles on her electric tricycle, which she loves, and she's out walking as best she can every day. It was a miracle, but very complicated. There were dozens, if not hundreds, of people involved in her care. There were tightropes walked. She gained 10 kilos of fluid during her surgery, and then diuresed it after her surgery. It was a tightrope, but it all came out right. How? Well, it would take me much more time than I have to describe it all, but it was because there was a symphony. There was a coordinated symphonic effort among many, many people, all of whom had the common aim of meeting Anne's needs. I once worked with a chemical company, of all things, who had as their value structure common systems, common knowledge, unconditional teamwork. I wish we could tattoo that on every physician and surgeon in the world. Those three ideas: common systems, we agree how to do things together. Common knowledge, what you know I can know, what I know you can know. And unconditional teamwork, which means you give before you take. You're always out to help others. That formula is magic, I think, and it's how Dr. Sunt and his team saved my wife's life. It's all about values and interactions with total transparency. I was on the team. They constantly asked me what I saw. They asked me what I thought they were doing wrong. Were they missing anything? They asked Anne all the time how it was going for her. Focus on what matters to Anne as the aim. How would you like to be? Technical skills were widely distributed, but that meant that people of very low status had very high technical skills, which meant if Dr. Sunt was the professor, that he wouldn't get the knowledge, and that was not Dr. Sunt. He was always asking, what did I do wrong? What could I do better? Of the lowest person in the hierarchy, we were totally lost. We were terrified. They weren't. There was a sense of orientation and teamwork. I mean, healthcare at its best can act with a beautiful symmetry and constancy, and that is not project by project. That is an ethos. That's an idea of who we are, which is we don't need commanders. We don't need captains. We don't need testosterone in the operating room. We need listening and cohesiveness, and it's bigger than projects, and it's what I call the second phase, and it is magnificent when it works. And Anne is going to ride her trike 30 miles tomorrow, I bet. That brings me to the third era of quality. Cara and President, I'm going to go over just a little bit if I can. It has to do with the pursuit of health and well-being itself. It's bigger than projects, and it's bigger than healthcare. It is the pursuit of health. And this involves a series of actions that I call collective actions. Just as in Anne's surgery, everyone mattered. In collective action problems, everyone matters, but on a bigger stage. This is examples of those. Climate change, which the World Health Organization says is the biggest threat to human health on the planet. Nobody's going to solve that, only all of us. And you can take a pass. That is, it's a collective action problem. So surgeons can say, well, that's not our lane. Anyone can say that. But we're never going to beat it unless everyone gets together and says, we're going to get on top of this. Equity is such a problem. Patient safety actually is such a problem. Healthcare costs, which are draining resources in my country, are a collective problem of collective action, in which the issue is about citizenship. And the hallmark is population health. I had a chance to meet with yesterday for half day with the new, somewhat new group in your Ministry of Health on improving health with populations, the public health group, and they can identify the determinants that will make us healthy or not. It's not an easy game. This is a quote from Albert Einstein on the entrance to our National Academy of Medicine. Einstein apparently said, "The right to search for truth implies also a duty. One must not conceal any part of what one has recognized to be true." And I think this applies to the pursuit of health, that the right to say we're engaged in the health enterprise includes a duty not to conceal what we know determines health. And that demands some courage. We had yesterday, my president announced that global greenhouse gases are not a threat to health. I don't know how he knows that. He disagrees with every climate scientist in the world. And we have a framework for that collective action problem. My favorite expert on this is Sir Michael Marmot, who I hope you will have speak here on this podium sometime if he's not. Michael's a brilliant epidemiologist, one of the most famous and accomplished in the world. He wrote a book in 2015 called The Health Gap, which I would put on the required reading list of every student of medicine or nursing. Michael took the world's literature on what creates gaps in health, enormous gaps in health, even across cities. There's the famous research done by Sir Harry Burns in Glasgow showing a dozen years of difference in life expectancy across one city. And Marmot says, what does that? Is it healthcare? Somewhat access matters, but it's really rather puny compared to what we discover in the literature creates well-being. The keys are in his book. The way he's organized it is 5 categories of creators of well-being and longevity. Early childhood experiences, which is the most powerful social determinant of longevity and well-being. Educational excellence across the board. Workplace conditions, including not just minimum wage, but security for workers. The experience of elders, the countries that have elder care systems that are well organized actually have better health for everybody. I don't know quite why, but that's the way it works out. And community resilience refers to the things like food security, housing security, clean air, restorative criminal justice systems, a list of community aspects. And Marmot is able to show in the literature how those dimensions are not just correlates, because there's causal research as well of lifespan. Nonetheless, we live with tremendous differences in lifespan across our cities, within our countries, not just among our countries. And in my countries at the bottom, I must tell you that for at least among OECD countries, the wealthy countries, we have the worst overall childhood experience in the United States, uneven educational access, workplace conditions that the EU has long since begun to remedy, no elder care policy that's meritorious, and no promise of a house over your head or a food security. It's quite an embarrassment. He says this is due to differences in fairness, that there's countries that succeed and live longer have a commitment to social justice. That's what health pursuit means. And so the question arises, how will we deal with inequities in health? And does the Royal College of Surgeons in Ireland have any responsibility for that? I think yes. I think the bigger expansion of the idea of quality, if we read our mission statements and the oaths we take, imply that we must be involved with collective action problems as part of the definition of professionalism and the duties of professional organizations. That's the next ring of expansion of the notion of quality. Does it mean that every cardiac surgeon needs to be involved in the pursuit of clean air? Well, maybe not, but maybe yes. Maybe there's a question about, are we going to be players in the creation of healthy society? And that leads me to the last and current era. the era of political engagement. We will not work on collective action problems. We will not work on clean air and safe streets and strong education and elder care policies unless we engage with the political world. There's no other way to do it. I mean, government is simply the word for what we decide to do together. And so if we're not attending to the determinants of health, we've made the wrong decision if we read our oaths. And I think we need to get active with that. My country, much more than yours, because we're in deep trouble. Twice the costs of any other country, any other developed country in the world, and much less health. Our life expectancy, you're way ahead of us in life expectancy. I think because perhaps in Ireland, like so many other OECD countries, you have a sense of fairness. Maybe, I don't know. We've lost that vocabulary. We've lost that moral imperative in America. Do not lose it in Ireland. Don't let you get seduced into the idea that it's all about money, or it's all about profit, it's all about more investment. It's not. It's about a commitment to each other. And that, I think, is the political side of the pursuit of quality. In my country, it is draining our resources. This is the rate of rise of healthcare costs in America compared to rate of rise of wages. And it's felt at the kitchen table. 100 million Americans now are in medical debt. No other country can say that. If Ireland makes the wrong choices about where to go with the health and healthcare system, you could end up in trouble. Don't. And as surgeons, don't ever accede to the idea that this is about money. No margin, no mission. If we have competition, that'll solve the problem. If we just have, focus on the bottom line, that'll solve the problem. It will not. It'll worsen the problem. And we have too many examples now of forgetting that if there's no healing, there's no mission. If there's no equity, there's no mission. If there's no sharing and no science, there's no mission. And I'm thrilled by what I see in the Royal College of Surgeons in Ireland. It's a magnificent institution, from what I can tell. Will you engage in the political agenda that avoids the kind of harms we see when policy goes awry? In my country right now, it means people losing their health care coverage. Hopefully you will never agree to that. The cutbacks in our investments in public health and the Centers for Disease Control is on its knees. NIH funding is cut back 30% or more. We've withdrawn from the international aid community, shut down our U.S. Agency for International Development, and we're walking away from the climate crisis as examples. Medicine, the House of Medicine, should be speaking up against this with, in my opinion, rage and confidence, compassion for a benighted public right now, and an agenda of political engagement. How much that might be needed in Ireland, I do not know. I sense more communitarianism, a better sense of fellowship and sisterhood in this country. Hopefully you will not be vulnerable to this. And I think it involves an active agenda by our leaders of healthcare to restore proper fairness and political will to the pursuit of health together. Rudolf Virchow said this in after studying an outbreak of typhus in Silesia. He saw the social determinants playing out in deaths. And he wrote that medicine is a social science. Politics is nothing else but medicine on a large scale. The physicians are the natural attorneys of the poor, and social problems fall to a large extent within their jurisdiction. That means, are the natural attorneys of the poor. I don't know if you agree with him or not, but if you do, then engagement is the fourth phase of pursuit of quality. Thank you again for your attention and a chance to join me.
I have a medal for you, so.
Okay.
So Dr. Berwick, thank you so much for really a truly outstanding lecture. And a very fitting note, and I think a very fitting challenge, in fact, upon which to bring our 2026 Charter Day meetings to a close. And I want to thank each of you here for being with us today and across the week. As I said earlier, I don't take your support and engagement for granted. And it's been an enormous privilege to bring this meeting together and to represent the outstanding surgical community that we have in Ireland. So to each of our guests, to each of our contributors, a very sincere thank you for being here, and thank you especially for the new perspectives that you brought to us, especially across the course of today. We have a fantastic team here in RCSI, and they've worked extraordinarily hard to make this week happen. Our events team, communications, fellows and members, front of house team, our porters, they all worked seamlessly to make this meeting happen. I'd like to say a very special word of thanks to Aoife Mahon, who played a central coordinating role. Likewise, Deirdre Mullen, you've heard about Cara, who is looked after our guests, Tevin Fareed, Porrick Kelly, Ciara Hughes, our entire organising committee for their outstanding work. I'd like to also thank our own IT team who worked closely with the team at Sound to Light, who were our audiovisual partner throughout the week. And I think you'll agree that our tech was flawless, so thank you all very much. Special thanks too to everyone in Surgical Affairs and the Sim Centre, and especially Simon Horn, who brought our technology and robotic learning village to light. Lastly, a final thank you to our sponsors who helped us in so many ways. I hope to see many of you here tomorrow morning. I think it's 9 o'clock sharp for the Irish Surgical Training Group. But for those of you leaving today, safe travels home, and we will see you at the Mill in November. Thank you.